Good morning, everyone. Welcome. The American Association of Neurological Surgeons is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The AANS designates this live activity for a maximum of 1 AMA PRA credit, Category 1 credit. As a provider accredited by the Accreditation Council for Continuing Medical Education, the AANS must ensure balance, independence, objectivity, and scientific rigor in all the sponsored educational activities. In accordance with the ACCME's standards for integrity and independence in accredited education, the AANS is required to disclose to the activity audience the relevant financial relationships of planners, faculty, and other individuals in a position to control content for this activity. Those who have disclosed a relationship with ineligible companies are listed on the current slide. All disclosed financial relationships have been mitigated in accordance with ACCME's standards. Planners, faculty, and any other individuals in control of content not listed have indicated they have no relevant financial relationships or conflicts of interest to disclose for this activity. Claiming credit will be available in our learning management system, NeuroU. Claiming instructions are on the screen and will be shared again at the conclusion of this webinar. By the end of next week, participants will receive an email notification of enrollment to claim credit. This notification email will also include the instructions on screen for your convenience. For any issues or questions regarding claiming credit, please contact education@AANS.org. Now, to get us started, I would like to introduce Dr. Hajipanayas.
Thank you, Patricia. Good morning, good afternoon, good evening. On behalf of the AANS CNS tumor section, I'm extremely happy that we're having another exciting webinar. This is being held by Dr. Sabino Luzzi from Sardinia. Dr. Maria Noor Olhuda will provide a more formal introduction shortly. This is another example of a great webinar in our series that are now recorded on our tumorsection.org website. Please refer to that for this website if you cannot join us today. I'd like to thank the AANS again for all their help with these webinars. They're so crucial to our educational mission. So I'd like to pass it over to Dr. Noor Olhuda for the introduction. Thank you.
Thank you very much, sir, for the very nice and kind words. It's a huge initiative of our section, and we have delivered a lot of, webinars on various different topics, hardly leaving anything. And it's under the very impeccable leadership of Professor Kostas Hajipanayas. It has been a privilege to do all this work and all these wonderful, educational activities. So it's a pleasure for me to introduce Professor Sabino Luzzi. He's a professor of neurosurgery at the University of Sassari and the Chief of Neurosurgery at AOU Sassari in Italy. He serves as the Vice Chair of Neurosurgery Residency Program at the Universities of Pavia and Sassari, and he is an active member of the WFNS Neuro-Oncology and Education and Training Committees, and also of the Young Neurosurgeons Committee. He's been really active in the last couple of years, doing a lot of educational activities on site and also online. He's an internationally recognized neurosurgeon, and he has authored more than 250 publications with key contributions to neuro-oncology, neurovascular and skull-base surgery, and also to all the recent innovative techniques and all those things. I'm a huge fan of your work already, and it was a privilege to cite a lot from your work in our book when I was writing a book with Professor Luis Borba. It was published a couple of years ago on neurosurgical approaches. I was able to get a lot of information from all his work, so I personally am a huge fan of all of the work you have introduced so far. So it's a privilege to welcome you today with us for this webinar. The floor is all yours. Please take your time and proceed.
Thank you. Thank you so much, Maria, for this kind introduction. And I have to really thank you to Maria and also Professor Hajipanayas for this kind invitation, and all the committee of the WNS and It's a big pleasure and honor for me to be here to share my humble experience in about the augmented reality in neurosurgery. If I can start, I ask you to kindly share my screen. Can you see my screen?
Yes.
Okay, thank you. So my topic for today is to share, as I told you, my humble experience about the intraoperative augmented reality fiber tractography and the experience that I collected in the last few years. And our group, to be honest, was among the first in the world to test this kind of technique intraoperatively and to test, the advantage and the benefits of augmented reality fiber tractography, both in the tumor surgery and also in neurovascular surgery. And I will show you some cases. When we talk about the augmented reality, there is a bit of confusion about the augmented reality. Why? Because augmented reality is part of the so-called extended reality. Now I will show you slides where we try to make some clarification about this concept. But I prepared this slide just to let you know, what the global and overall interest in terms of extended reality with three different forms: virtual reality, augmented reality, and mixed reality. This is the cumulative volume of literature about the topic until, this slide is updated up to October 2025. And this is also Cochrane Library, and we have some studies, ongoing trials about the topics. And, this is the number of trials. This is just to let you know what's the global and overall interest in this topic, especially in terms of augmented reality that prove it to be very practical. As I told you, extended reality, just for clarify, has three main pillars. The first one is the virtual reality that could be immersive and non-immersive, but it is very, widely used in 3D computer generating environment and, companies. And then we have augmented reality. Augmented reality basically involves the use of superimposed 3D computer generated virtual objects, as you see here in these slides. And it has been until now, up to now, one of the most used in medical practice. And then we have the mixed reality that is another emerging, pillar of this form of extended reality. Augmented reality in general, and especially augmented reality, has been used especially in brain tumor surgery because of the several benefits that it allows for. And now I want to show you some purposes on about why to use augmented reality and which field of brain tumor surgery mainly uses augmented reality. The first field is to planning. Obviously, this is not a novelty in brain tumor surgery, but fiber tractography has been extensively used in planning. Why? Because we, plan our surgical trajectory across not across, but aimed to avoid to cross the white matter fiber tracking. And then the real novelty and the main topic of this lecture is the implementation of the execution of the augmented reality in brain tumor surgery. And then our group and other group also extensively use the augmented reality also in post-op assessment of residual connectivity, because everybody should critically appraise, the residual connectivity after surgery, because the main concept of the minimal invasiveness of surgery is always the same. So to be respectful of the anatomy as much as we can, and we have to critically appraise how much invasive was our surgery and whether or not we were able to spare this connectivity in terms of white matter fiber tracts. This is, an overview of the planning of surgery here. For sure, we plan, as I told you, some specific trajectory that should be aimed to avoid every kind of critical and what they call, eloquent white matter fiber tracts. One of the most important aspects is the fact that the excision are always more important than incision, that Robert Salter already said several years ago. And then execution, we have several types of, use, especially of augmented reality fiber tractography, but also augmented reality in general, because the use of tracer like ICG, fluorescein, 5LA are other forms of augmented reality. And this context, worth to be stressed, as I will show you in some videos also. And then, as I told you, postoperative residual connectivity, this is a case that I will present here where we want to, after surgery, see how invasive was our surgery in terms of sparing the main critical white matter fiber tracts. Just to introduce, this is the operative room setup for augmented reality fiber tractography. As you see here, the main important aspect is that what you see is what the surgeon see in the eyepiece of the microscope. Apart from this, we can have an extra head-mounted or external displays, as you can see here, and the audience and the surgeon can critical reappraise and critical review this kind of surgery in an update fashion here. And also, this is a case, this is the first case that I want to introduce. This is a post-central gyrus high-grade glioma here. And as I told you, I always perform preoperatively the DTI because I want to study in detail the relationship between the tumor or my lesion that I want to remove. Also, cavernoma, for example, or AVM, we use this kind of technology in every kind of lesion, but especially for sure in brain tumor surgery. And this is another form of the augmented reality. We see a superimposed picture of tumor, and this is exactly what the surgeon see in the eyepiece of the microscope. And here in this video, we have different forms of the augmented reality merged all together. We have ICG, we have fluorescein and everything, but especially what was really helpful was the direct visualization of the corticospinal tract in this case, because the corticospinal tract was, as you see, just in front of our lesion. And for sure, the target of my surgery is to take it out all the tumor and sparing the corticospinal tract. As you can see here, when you move the microscope, the holographic and superimposed images moves around the target. And apart from this, we implemented here all the basic techniques of, transsulcal, transcisternal approach, like Professor Ashagi taught to all of us. And this is the surgical field at the end of surgery. And another aspect that I want to stress that you can vary the depth of the microscope, and varying the depth of the microscope, we can vary, the depth and the visualization of the amount of the corticospinal tract. And this is the patient after surgery, and we just saw the residual connectivity, the post-op DTI that usually we perform around the second or third week after surgery. As you can see here, as I told you, we have here different form of we have different forms, of augmented reality, white light, ICG, yellow, but especially DTI-based fiber tractography and the main steps of surgery. And this technology is, is helpful during surgery. For sure, the technology doesn't make surgery, as I say always. You have to know very well the anatomy. In this case, I perform, post-central sulcus approach here just to try to do my best to remove the lesion and to, spare the corticospinal tract. But it is very helpful because at the end of surgery, we see what we do. And for sure, as I will stress later on, this kind of technology should be coupled also with brain mapping, because this is just an overview of the structural connectivity, but doesn't provide any information about the function of the white matter fiber tracts. This is another case. This is an insular high-grade glioma here. So one of the main criticism of the reviewer when I start to send the first paper about this kind of topic was the fact that maybe augmented reality, especially this form of the augmented reality, was good for superficial lesion, not deep-seated lesion. This is the proof that it was not true. We treated so many, insular glioma here. This is a case of a male patient, 63 years old, suffering from new onset sleep-related hypermotor epilepsy here, and these are the main steps of surgery. I want to stress also that in all the cases of insular glioma, I have never performed transopercular approach because I'm totally against transopercular approach, because the insular tumor transsylvian approach is more than enough. I try to do my best to avoid any retraction, any spatula, because in neurosurgery, the best retraction is no retraction. As you see here, I like to perform this kind of surgery, always just performing a wide splitting of the Sylvian fissure. the most expert colleague always say that this kind of surgery is very close. It's basically vascular surgery because it's a surgery where we have to be very respectful of the MCA and all the branches. And these are the steps after surgery. I perform large part of this surgery after, under direct visualization of the white matter fiber tract, especially of the IFOF and also the corticospinal tract that was posterior to this lesion. And also at the end of surgery, I like to check the patency, the residual patency, the flow of the MCA. And this is another proof that augmented reality is very helpful in this kind of cases. And this is the post-op patient, a few days after surgery. But after starting to implement this kind of technique in my routine practice, my question was, can augmented reality take really advantage in terms of the increase of what they call maximal safe resection of brain tumor? I don't like to use this kind of technique because every resection should be safe. But anyway, when we talk about the gross total resection of high-grade glioma, we want to stress the fact that we have to spare this kind of white matter fiber tracts. And we were very lucky because we published the early experience of our study in JNS, and this is an overview of my series here, my overall series at very early beginning. I use this kind of technique in every kind of lesion and every site of lesion, frontal, central, parietal, temporal, limbic, and occipital also. And very interestingly, we found that the post-op nano score, so in terms of neurological function, was better, a bit better in terms of augmented reality compared to the control group that where non-augmented reality assisted surgery was performed. And also we have a slight bit, maybe because of better spatial awareness about the location and three-dimensional location of the white matter fiber tracts. We have a better gross total resection and plus the near total resection group. And obviously we have better progression-free survivals for this lesion using this kind of technique, and we prove this kind of data. Another site where augmented reality, especially fiber tractography, was super helpful in my experience was the primary motor area, the M1 area here. As you see, this is one kind of tumor, and for this kind of tumor, I implemented a special protocol where we want to always assess where the tumor, displays posteriorly or anteriorly, or the tumor aroused, like in the last case that I show you, and then tend to split the corticospinal tract. Why? Because this concept is super, super helpful for me to plan the approach. That's the reason why, as I stressed at very early beginning of my lecture, tractography and fiber tractography is fundamental, especially in planned surgery, because in some cases you can go from trans precentral sulcus. In other cases, you have to switch to trans postcentral sulcus to remove this kind of lesion. But in other cases, especially in the cases where you have that the lesion and the tumor arose exactly at the level of the corticospinal tract, these lesions tend to split the corticospinal tract, and in these cases, it is better to perform a direct transarterial approach because it's paradoxically more conservative than other kind of approach. These are some cases of primary motor area glioma, because we perform this kind of surgery in glioma, but also in metastasis and also in cavernomas, because the concept is the same. This is a case of a female 65 years old suffering from seizure. This is a very small but challenging and super challenging tumor because it arose exactly at the level of primary motor area. And these are the main steps of surgery. I always like to plan this kind of surgery, as I told you, with T1, T2, and review several times before to go there, especially when you deal with this super eloquent area. As I told you and I stressed, in this kind of surgery, you should always to couple this kind of surgery to neuromonitoring, because this kind of technique just allows to some structural anatomical information, but not functional information. Exactly for this, so because of this, I stress it so much in all my papers, the fact that we should couple this kind of technique to neuromonitoring to achieve the best solution to our patient to decrease the likelihood of postoperative deficits. And also, as I told you, most of this surgery is performed under direct visualization in a modular way in terms of superimposed picture of the corticospinal tract, IFOF, and the main bundles that are, for sure very close to the lesion that I'm gonna removing. And this is the post-op MRI. The tumor was taken out, and in the post-op MRI, we remove all this tumor, and the patient have no deficits and no deficit. That obviously, sorry, this patient tend to worsen after surgery. But if the structural residual connectivity is good, this patient tend to recover after 2-3 weeks. And this is exactly what we proved in another paper from JNS about the impact of the augmented reality, especially on the primary motor area here. And in this, for this specific tumor, we proved that the rate of the intraoperative seizure, that is another one of the most important aspects, was lower when we use this kind of technique. And 3-month post-op nanoscore was better with augmented reality fiber tractography. This is because we were more conservative because of the better spatial awareness of the corticospinal tract, especially in this area, but also the SLF1, 2, and so far. And also the motor score was better in this kind of patient because it's strictly related to the best performance of this patient. We compared 34 lesions in terms of glioma, and mets also with the control group. And in terms of progression-free survival, exactly from the same result that we stress in the previous article about our overall experience in terms of augmented reality. In both gliomas and mets, we have a better progression-free survival of this patient because we were able to take it out, to take out a bit more of tumor. And we know very well that the more tumor we take out, the better the progression-free survival the patient is. For sure, this kind of technique is not able to affect the overall survival of this patient because it is not related to the, natural history of this kind of lesion. We have the privilege also to implement this kind of technique also in neurovascular surgery. When we talk about neurovascular surgery, we know very well that the goals of the augmented reality in neurovascular surgery are different. The first goal, especially for intraaxial lesion like cavernoma or, also AVM, we need to increase the awareness about the spatial orientation of the surgeon and the near-boring white matter fiber tracts. And also, when we talk more in general about the augmented reality, and not only the fiber tractography, we need also to check the blood flow during our surgery or after our surgery to be sure that we didn't do any damage to the patient. And in doing this, we can use also the intraoperative video angiography. That is another form of the augmented reality. It could be ICG based or also fluorescent based. And here we have different modules here. And this is just an overview of different cases of aneurysm also, where we use this form of augmented reality. We can use, ICG, we can use fluorescent, we can use this kind of, new tracer also for AVM surgery. But I was very, happy when I started to use this kind of techniques. So fiber tractography for cavernoma surgery for sure. And this is a case that I want to show you. This is a female 36-year-old suffering from seizure. And this is the gradient echo. As you can see here, this is a primary supplement. This is a supplementary motor area cavernoma, very huge. And we started to use this kind of technique at the very early beginning of surgery. For sure, you don't need to plan the craniotomy of this kind of technique, but this is nice to see in this superimposed X-ray vision, the location of the lesion. And for young guys, it's not bad to have at the very early beginning of surgery the tumor under constant visualization and to also tailor craniotomy. This is the exposure of the left superior frontal sulcus. In every kind of surgery, I implement what we learned from Professor Yashagi in terms of transsulcar transcisternal approach. And in this case, we were working very close to the SLF1 and just posterior to this kind of lesion, especially in the depth, we have the primary motor area and the corticospinal tract. Here, I perform an opening with sharp dissection of the superior frontal sulcus, and I just expose it immediately at the depth of the sulcus here, the cavernoma. The basic step of surgery are always the same. I use the basic principles of microneurosurgery here. And when I had the opportunity, I tend to remove the hemosiderin stain to decrease the likelihood of postoperative seizure here. These are the main steps of surgery. This is surgical field at the end of surgery, just after opening. As I told you, the ICG check, everything was okay. And it was the MRI after surgery, and we were super conservative. And this is the patient a few days after surgery she was discharged on 4th post-op day without deficits. And it was another example of how to use and to implement this form of the augmented reality in our clinical practice. Apart from this, there are some advantages that I want to stress in terms of implementation of the augmented reality fiber tractography in brain tumor neurovascular surgery. This technique allowed us to perform a pre-planning of the surgical target, increase the awareness about the spatial orientation of the white matter fiber tracts. This technique proved to be a very good safety profile, not involving tracer or dice, because it is absolutely non-invasive technique. And also, it is repeatable because we use multiple real data sources, and it is available also for asleep and awake surgery. Also, there are no contraindication to use this kind of technique in awake surgery patient. This is not real time because for sure we are not talking about ultrasound. We're just talking about optical tracking and common, conventional navigation. But this is continuous and updated navigation because this technique allows for a brain shift correction through what they call the elastic fusion model of brain shift correction during surgery, time by time, especially when we perform a huge amount of CSF withdrawal. But there are for sure some limitations that are worth to be discussed. There are some technical constraints related to the technique. The first one is the fact that this is a structural anatomical, but this technique provides no functional information, and I stressed several times. So that's the reason why we need to integrate this kind of technique with some functional mapping techniques. Another important clinical aspect, critical aspect, comes from the physics, and that should be stressed is the concept of the parallax. And the parallax is a shaking, is a little shaking when you move the microscope because the source of projecting of the augmented reality is different from the acquisition of the augmented reality. But this physical error could be, reduced with the point lock function. You should move the microscope just a bit around the target and performing and implementing some micro movement rather than macro movement. Another important aspect is the potential, crowding of the fiber tracts, and to decrease the potential, crowding of the fiber tracts, we need to opt for some modular selection of the tracts involved, because sometimes the crowding or even overcrowding of these fiber tracts can, hinder some neurovascular obstruction and could be, the source of some complications. So we need to be very careful. That's the reason why my advice for the people that want to start to use this technique, it is to opt and to perform some modular selection and to switch on and switch off during surgery one by one, or a maximum 2 different white matter fiber tracts. This is, for me, the source of the future. This is just an example to show you what we can see today, what we can have today. It is a 7 Tesla Harty MRI. Usually when we use this kind of technique, we don't use still in our clinical practice the probabilistic model. We use just a deterministic model of fiber tracking, but this is the reality. This is already available for clinical practice, but our target should be to implement this kind of definition also in our intraoperative visualization of the white matter fiber tracts. And this is also a stimulation to be more conservative on the anatomy and more respectful of the anatomy of our surgery, because everybody should be critically appraisal at the end of surgery of how much we were respectful of the anatomy after our surgery. And I want to thank you so much once again for this kind invitation, and I'm here for some questions for everyone if you want to ask me some question about how to start on down to implement this kind of technique. Thank you so much once again.
Thank you very much, Dr. Lucy. That was an incredible talk. Beautiful cases. Um, I had a couple questions. I know, as you mentioned, the mapping part of this is so important in terms of ensuring functional preservation. Can you tell
Yeah.
us a little bit about your approach in your cases in terms of what particular mapping techniques you employ? And then the other thing I wanted to see, pick your brains, we've had, some recent webinars on the connectomic uh, hubs and other types of pathways that we're now considering during surgery, and there's some exciting work being done there, and kind of what you think of that too. Thank you.
Yeah, so thank you so much for your kind question. The first question is the mapping. The mapping is a critical part, as I stressed it several times during my lecture. The mapping depends from, the concept of the choose of which kind of technique is not related to the augmented reality. I just choose this kind of technique according to the site of lesion and to the kind of lesion. As I showed you, especially in primary motor area tumor, I prefer to use a direct cortical stimulation because it's very sensitive and is very, very, specific for this kind of tumor. For that cases, there is no reason to perform that kind of surgery in awake surgery. I'm not against the awake surgery, but sometimes it introduces some discomfort for the patient and for the surgeon also. And we know very well that there are some risk also the intraoperative seizure. So for that kind of lesion, I prefer to perform direct cortical stimulation. I use the grid and I use everything about that, and also the probe time by time. For other kind of deep-seated lesion, I use, transcranial stimulation. Sometimes when I am very close to the central sulcus, I use for sure the reverse some different kind of technique also to have the information and to early identify the central sulcus, and the phase reversal technique, I mean, and nothing special apart from that. About the second question about the connectome, yes, very important, and that's the reason why the connectomic is very important. We start to use the quantity of residual connectivity now with DTI, and this is a technique, not a technique, but this is another point that we should couple with the intraoperative DTI to create a continuum that should follow what I show in terms of the surgical workflow. For sure, in this kind of lecture, I just focused on the surgical and intraoperative workflow, but what is behind the line of the end of surgery is very, very important, because the connectomic and the residual connectivity is maybe one of the most underrated aspects of the brain tumor surgery. So I totally agree with you about the fact that we should focus on the implement this kind of surgery, because we have an objective tool to quantify our invasiveness in terms of surgery, especially in intra-axial lesion, I mean.
Well, thank you, everyone.
Okay. Wonderful.
Yeah.
Maria.
I heard maybe one attendant, maybe there is another question from the audience. I'm here totally available.
Well, we actually had a very interesting talk by Professor Michael Sucro, on personality and all the tracks that we discussed in our last webinar. So, and one of our colleagues have actually published a paper, Dr. Aristotelis has published a paper on the somatocognitive action network, the SCAN network, and that was very interesting to explore that we are not only going to talk more about the motor and the speech areas, but speech preservation and the motor preservation, but also about the personality preservation, if that's possible. But obviously, it's not that much of a focus like preserving the motor function or the speech function. But it's like we have got a lot of this concept of connectomics into play, and it's very interesting to explore that as well, if that's really a problem. But there's also one question in my mind, sir, when we talk about this tractography, the detail-based tractography. In AR-guided surgery, can we reliably distinguish between tract displacement and, in metastasis, it's more likely that we are going to have these tracts displaced, but there are gliomas that are infiltrating those tracts, and there could be a pseudo disruption due to vasogenic edema. So do you think that how would you adjust and how would you interpret in the case if you are going to perform this tractography for gliomas versus the metastases, or how would you adjust if there's more vasogenic edema that might affect the AF and all this thing? How do you think about that?
Unfortunately, there are some technical constraints, as I shared, as I told you. I just focus on the technical constraints and or intraoperative technical constraints, but there are some technical limitation of the DTI during the planning of surgery. And unfortunately, a huge edema is the worst enemy of the accuracy of tractography before surgery, because we have a huge rate of distortion of the white matter fiber tracts. But there are some algorithms, and today they are, working so hard on, differentiate this kind of, situation where the tract is infiltrated or distorted. Another important limitation is the method of acquisition of DTI. We use the deterministic algorithm, but with the progressive implementation of what they call cube ball, so probabilistic algorithm, they are now already be able to perform a beautiful intravoxel better resolution, because you have some oblique, study, you can catch some oblique direction of the water, of motion of water, Brownian, what they call Brownian motion of water inside the axons. So I do believe that maybe with the progressive refinement, with progressive implementation and the refinement of this new method, that is probabilistic algorithm, we will be better, we will be, able to perform this kind of, this is basically differential diagnosis in between, the infiltration and the distortion of white matter fiber tract. So I do believe that maybe that's the key for the future.
Yeah, we're doing some work with multi-shell DTI. And I think that's, Sabino, that's a way to kind of minimize the edema effects on
Yeah.
portion of the tracks. A lot of that stuff's been done at the University of Pennsylvania, but we've teamed up with them to kind of look at that and use the exoscope and we with tractography and so forth. But yeah, exciting area, very important.
I just want to add a comment about the fact that some limitation of the DTI are also greater in some location, and when we deal with some specific fiber tracts. For example, everybody knows that at the level of what they call posterior thalamic peduncle, so optic radiation,
Yes,
there are a huge intermingling rate of the fibers. For example, at the level of the sagittal stratum, we have 4 layers of fiber, because we have the anterior commissure, we have hypophysis, we have posterior thalamic peduncle, temporoparietal occipital fibers. There is a beautiful article that just came out from the Professor Ture group, that is my mentor. And, when they demonstrate that in that area, you have 4 layers of white matter fiber tracts. So the spatial discrimination of the DTI is, unfortunately limited in that kind of area. So we should work very hard, to differentiate that kind of, but, it's so easy to, perform that kind when we are work with very close to the corticospinal tract, extreme capsule and everything, but not at the level of the sagittal stratum. And this is another further limitation to be mentioned.
And do you think there's any hope to extrapolate this, ma'am? This technique, it's a very complicated thing in the case of infratentorial lesions. But do you think that we would ever be able to attain that goal as well someday? Because it's going to be very beneficial if that's possible, but that's not very possible. I believe infratentorially.
Yeah, you mean in the extraaxial lesion or something that is beyond the limit of the intraaxial lesion? This is our question, if I'm not wrong. Correct me, please. Yeah.
No, I'm asking about that infratentorial lesions. In the case of
Infratentorial,
that's
yeah,
very
sure.
complicated. Yeah.
Sure. Infratentorial lesion, for sure, it's the same, especially when you talk about, brainstem. I don't have experience, to be honest. I just, started to treat this kind of issue. I just treated a couple of lesions, very simple, in posterior fossa. I don't have a huge experience with posterior fossa. Maybe it will be the next step. I just have huge experience, wider experience for supratentorial surgery, but for sure, why not for posterior fossa surgery, especially for, once again, intraaxial lesion, where we talk about, corticobulbar or medial lemniscus, lateral lemniscus, especially when you deal with some cerebellar peduncle lesion or brainstem lesion. You can have some advantages in implementing this kind of technique. Why not? In the future, this is our commitment for the future.
Exactly. That would be amazing. We have got a couple of questions in the question box. Dr. Jeremy Reyes has asked, excellent talk. And based on your experience, how accurate and reliable do you consider tractography and conductomics, and what level of confidence do you have in using them for clinical or research decisions?
Yeah, it's a different question to, because nobody can tell, it proved to be accurate. The main limitation in terms of the accuracy of the TI is the brain shift, because, it's an updated but not real-time technique, as I stressed it several times. So when you have a very huge amount of frame shift, for sure you can have, the decrease in the accuracy of fiber tracts only position. So in doing this, the key to test the accuracy, if it's the same answer that we can have in terms of frame shift correction. Now with modern navigation system, we have some algorithms in terms of frame shift correction. And that's the reason why I used this kind of technique also in terms of frame shift correction, and the accuracy was not bad. I was able to realign manually. It's a semi-automatic method where you technically should, realign, because the landmark are the cortical vasculature, especially the arteries on the venous vasculature. And when you have a mismatch, and you can see the mismatch, in terms of real surgical field and navigation, non-updated navigation, you can realign and reduce the frame shift and to increase the rate of the accuracy of your kind of technique. And this is useful because nobody can quantify in terms of millimeters the accuracy, because we don't have that kind of technique still. But in my experience, was not bad. But I want to stress another concept in terms of, how this is very nice tool. I use this very nice tool. I'm very happy when I use this kind of tool. It's xenographic, it's good, but it's absolutely not substitutive of perfect knowledge of the anatomy. So in my humble experience and my humble opinion, we can use this kind of technique all together: augmented reality, fiber tractography, ICG, everything you want, but especially for the young people, the take-home message should be, I have to know perfectly the anatomy, because the anatomy is the only aspect that decrease, the risk of complication after surgery, and every kind of high-tech technique, high-tech, method is not able to, do surgery. You have to do surgery, and to do surgery, you have to have, in your basket, perfect knowledge of the anatomy. So that's my reply to this
Well
question.
said.
And we have another one after navigation
Hey,
of
one more question.
Yeah.
Yeah.
After navigation of tracts during microsurgery, how you can differentiate between infiltrating lesion versus
Infiltration?
Yeah. There is no way apart from your experience. And we have different, not technique, but tricks that you can perform. And these kind of tricks have been already elegantly described several years ago by Professor Yashagi. For sure, there is a difference in terms of consistency of, brain tissue, because the infiltrate. I don't like to, use this kind of infiltration, because the true infiltration has been proven to be present only in the super late stage of gliomas. In most of the cases, glioma, it's in most of the cases, especially when they are at the lobar stage or subcortical stage, they are still defined within some certain compartments. That's the reason why we need to go there. We need to reach the limits of the tumor, to take out all the tumor, and to do our job without damaging. And it is super possible. It is absolutely possible. And I show you some cases where the boundary of the tumor were not absolutely clean. And to reply to this answer, my answer is the experience. Another important aspect apart from the consistency is the sound. When sometimes you can suck the tumor under your aspiration and under your suction tube, and the sound after the suction tube is totally different when you are, removing tumor and when you reach the boundaries, because the sound is more obtuning, it's more obtuse the sound when you reach the good and the healthy white matter brain, and what the healthy brain compared to the infiltrated brain and tumor that is more acute sound and more noisy. So, but for sure you cannot differentiate with this technique the rate of infiltration. This is another, if we want, limitation of the technique. The technique is nice to increase once again your spatial awareness about the orientation of the corticospinal tract, of the main white matter fiber tract, not only corticospinal tract.
Okay. Well, once again, thank you, Dr. Lutzi. Wonderful talk. I think
Thank
we
you.
all learned a great deal, and we thank you for taking time out of your day. And Maria, I just want to say a few words at the end.
Thank
Yeah.
you.
Good.
Thank you so
Thank you
much.
very
I want to thank you once again, all of you, and especially, all the people that are connected now, and all the people that will review and will see this video on web. And please contact me, and you are more than welcome to come to my hospital to see directly with your eyes, what we do every day, and you are more than welcome. We have some open program in terms of visitorship or observership or fellowship also, and you can contact me. I put my email address, and you can come. You're more than welcome. Also, you, Professor Ajipanais, I
Love to
wait
come
for you
visit.
in the nice Sardinia.
Yeah, Sardinia is an amazing place. I'd love to come see you.
Yeah, and Maria also, you are more than welcome. Can't wait to see you and to have you as my guest. Okay.
Okay.
Oh,
Thank you
sure.
very much.
I should be joining you as a fellow.
Yeah, sure.
And I love doing fellowships all the time. So I'm already, planning to do
Please,
another fellowship. So I'm going to come to you,
please come.
and Dr. Haji Panayet, he's a wonderful mentor. I've been telling him that he's one of the best
I
mentors.
know.
Yeah, and one of the best chairs to work with. I've been working with several people. He's so amazing, so insightful, and always full of ideas and full of knowledge. So you both are
Thank you
huge
very much.
inspirations for me.
Thank you.
All right.
Thank you very much.
All right. Well, have a great
Appreciate it.
weekend. Thank you. Bye.
Thank you
Thank
very
you.
much, sir.
Thank you.
Thank you very much.
Bye-bye. Bye.